Hello, my name is Dr. Michael Niederman, Professor of Clinical Medicine at Weill Cornell Medical College and Associate Chief in the Division of Pulmonary and Critical Care Medicine at New York Presbyterian Weill Cornell Medical Center. Today, I'd like to discuss with you new guidelines for severe community-acquired pneumonia. I've listed here my financial disclosures relevant to this presentation. The goal of guidelines is to help us optimize the initial management of severe community-acquired pneumonia. That means early recognition of severe illness, disease presence, and pathogen diagnosis, defining the proper site of care, assessing severity, and using biomarkers to add to that assessment, the use of supportive care, which may include high-flow nasal cannula and non-invasive ventilation, proper antibiotic selection, and adjunctive therapy, which can include corticosteroids. There are many challenges in the management of severe community-acquired pneumonia, and a number of us who were included in the new guideline committee wrote a review that was published last year. Some of the key points from this review include that the IDSA ATS Severe CAP tool is the best tool to define need for ICU admission. A beta-lactam macrolide combination should be used for everybody, but coverage of the pest pathogens, which I'll discuss in a minute, should be added if there are at least 2 risk factors for these pathogens. Oseltamivir should be used without steroids for influenza, and steroids should be considered for severe community-acquired pneumonia in the presence of high levels of inflammation. The pest pathogens include Pseudomonas aeruginosa, ESBL-producing Enterobacteriaceae, and MRSA. And these pathogens are present in somewhere between 6 and 10% of all CAP pathogens and all CAP patients. And the risk factors for the pest pathogens are listed here. They include hospitalization for more than 2 days in the last month. They include systemic antibiotics in the past 3 to 6 months, chronic underlying lung disease, and many other risk factors that are known to predispose to infection with these pathogens. This concept was originally developed by Dr. Torres and his colleagues in Barcelona, and the slide here shows a modification by Webb and colleagues from Utah. In the new guidelines, a group of approximately 20, including 3 junior writers and advisors, appointed by the ERS, ECMID, ISICEM, and other groups, are writing guidelines around 8 PICO questions. A PICO question refers to a question that defines a population being studied, an intervention, a comparator group, and a desired outcome. And the PICO question is posed, and the evidence is reviewed to define what the outcomes are for the population, the intervention, and the comparator group. This group of guideline individuals is led by Tony Torres and Ignacio Martin Loeches. There are 8 PICO questions, and I'm going to quickly outline for you what those 8 questions are. The first refers to rapid diagnostic methods, and the question is, in patients with severe community-acquired pneumonia, does adding specific rapid microbiologic techniques to current testing of blood and respiratory tract samples enhance the frequency of an etiologic diagnosis compared to conventional methods? So here you see the PICO method. The P refers to patients with community-acquired pneumonia that is severe. The I is the intervention of rapid diagnostic methods. The comparator is a group that receives non-molecular conventional diagnostic testing, and the outcome is a microbiologic etiologic diagnosis. And these PICO questions all work in the same way. 8 of them have been defined, and our group will be giving the answers to these 8 questions. Question number 2, in hypoxemic patients with severe CAP, can either non-invasive mechanical ventilation or high-flow nasal oxygen be used initially rather than supplemental standard oxygen to avoid intubation and reduce mortality? And I just want to highlight why this is an important question and some of the data we may be looking at. We know, for example, that delayed intubation is a predictor of a poor outcome in community-acquired pneumonia. This retrospective analysis of prospectively collected data of 100 intubated patients with CAP showed that for the individuals who were intubated within less than 3 days, the survival was greater than if there was a delay in the initiation of intubation to greater than 3 days. Delayed intubation was associated with a higher 30-day mortality, higher ICU mortality, progressive respiratory failure. So we want to avoid delayed intubation or intubation altogether, and we may be able to do that with certain supportive modalities. This is one of the key studies that our group has looked at. It was a study of 300 or so hypoxemic patients with respiratory failure. 2/3 of these patients did have community-acquired pneumonia, and they're randomized to high-flow nasal cannula, standard oxygen, and non-invasive ventilation. And you can see that the lowest mortality was achieved with the high-flow nasal oxygen system, better survival than the use of non-invasive ventilation or standard care. PICO question 3 is, when using initial empiric therapy for severe community-acquired pneumonia, should a macrolide or a fluoroquinolone be used as part of combination therapy in order to reduce mortality and adverse clinical outcomes? And question number 4 refers to biomarkers to reduce the duration of therapy. That question is, in patients with severe CAP, can serum CRP or procalcitonin be used to reduce the duration of antibiotic therapy and improve other outcomes compared with standard of care that's not guided by serial biomarker measurements? Again, the use of macrolides in severe CAP has been discussed for many years, and this is a meta-analysis from several years ago that looked at nearly 10,000 patients and showed that the addition of a macrolide to the therapy of severe CAP was associated with a 20% or so reduction in mortality. And the adding of a macrolide to a beta-lactam appeared to be more favorable for outcome than the addition of a fluoroquinolone to a beta-lactam. There are subsets of patients who may benefit particularly from the addition of a macrolide. And in this study that we did looking at 1,700 patients with CAP and a known cause, some got a beta-lactam macrolide, others got a fluoroquinolone with or without a beta-lactam. And the beta-lactam macrolide was associated with the lowest mortality. But after a propensity score adjustment, the group that benefited the most from the addition of a macrolide to a beta-lactam were those with high levels of inflammation, as reflected by a high CRP and pneumonia caused by pneumococcus. And that's clearly shown in this 30-day mortality prediction. Also, not all macrolides may be the same. And in the POSTMA study, which is a well-known cluster randomized trial that included macrolides and other agents for the treatment of community-acquired pneumonia, macrolides were associated with a relatively high cardiovascular event of 8.8%. That was higher than with a quinolone or a beta-lactam alone. But interestingly, if the individual macrolides were examined, azithromycin had a much lower cardiac event rate than clarithromycin or erythromycin. And possibly this could be related to the fluid volume that's needed to give something like erythromycin compared to azithromycin. And again, the data from this study showed higher cardiac events, although not more heart failure, specifically in the erythromycin group. But again, not all macrolides may be the same in their benefit. The 5th PICO question relates to influenza and oseltamivir. Does the addition of empiric oseltamivir to standard therapy in patients with severe CAP and suspected influenza lead to improved outcomes, such as mortality, length of stay, duration of mechanical ventilation, compared to standard therapy alone? And number 6 relates to steroids. Does the addition of steroids to antibiotic therapy in specific severe CAP populations lead to better outcome compared to not using steroid therapy? These are 2 vitally important questions, and we've faced these in dealing with COVID. But we know from a meta-analysis several years ago that in patients with community-acquired pneumonia, those with severe CAP have a possible reduction in mortality with the use of corticosteroids. And it's the group with severe illness, not mild illness, who benefit the most. But when we use corticosteroids in the setting of influenza, there's actually harm that may occur because steroids may increase the mortality with influenza and may be also associated with delayed elimination of the virus. As you know, this led to some caution with the use of corticosteroids in COVID, but we've also found that in COVID, corticosteroids appear to be safe and effective. So the algorithm for using corticosteroids is in severe CAP We look for patients with a high level of CRP, greater than 15 milligrams per deciliter, and we exclude patients who have influenza. We monitor CRP and give corticosteroids. And in another review, again, we suggested the same type of algorithm. The last two PICO questions relate to broad spectrum antibiotic therapy and risk-based therapy. Number 7 is, does the addition of broad spectrum antibiotic therapy based on risk factors for non-core pathogens, this is the PES pathogen concept, lead to more appropriate therapy and improved outcome compared to the use of therapy directed only at the core pathogens? And the final question is, do patients with severe CAP and aspiration risk factors have a better outcome if they're treated, again, with a risk-based regimen rather than standard therapy? And all these questions will be addressed. And our goal, again, is to optimize initial management of severe CAP, which is, again, summarized here. I thank you for your attention, and I hope that you, as I, look forward to the final version of these guidelines. Thank you.